Hello. Hello, dear colleagues. Here is Dr. Roxana Ilic telling you welcome and hello. Thank you for being with us this afternoon. Hoping that you want to hear many answers to your questions about the adhesion of adhesive dental systems to enamel and dentine, and of course to other materials as to the restorative ones. I don't know if we should wait or not for other colleagues of us, but maybe in respect to the ones that were very punctual and present to our dear Radosveta, hello, a big heart also from Romania to my colleagues from all over. Radosveta from Bulgaria, it's a colleague of mine in collaboration. Hello, Lazar as well. Hello. Danica as well. Hello, I'm from Romania. Where are you from, dear colleagues? So Radosveta, I know it's from Bulgaria. I hope one day to Sofia or Balcic to go. Lazar is from Serbia. Yes, big hello to all the Serbians, because maybe you have noticed I have a Serbian name. My mother and also my husband, they have a Serbian part of origin from over there. Also Macedonia, Montenegro. Hello, Yuka as well. Thank you, everybody. Hello from Serbia. You know, right now I am talking to you from I have some slides from Bucharest, greetings, but I am to my mother's home in this epidemiological particular times, on the border of the Danube, also the colleague. And of course, we have to say hello to our host, let's say, Darius Miskevich. It's our clinical affairs manager for Eastern Europe that has made possible to have this meeting together. And I hope we will all enjoy our meeting today. Yes. And also our Darius has a special day because it's his birthday today. I didn't know. I hope we will manage well to make him a good gift. Sinisa, hello from Serbia. Yes, I've told you I'm on the border of the Danube, and if I want to look over the Danube, I see Serbia. I'm in Moshova, on the border. I have to say to my colleague Darius that I think we hear him, so he should put his microphone. Now he is fine. Okay, Darius. Also from Bulgaria. So we are colleagues and neighbors, all of us. Today, as you have seen from the title of the event of today, of our webinar, we are going to deal with the adhesion topic. And at this moment, I think you can see also my my webinar that was opened already, and I have made a kind of preview also for my colleague. I will start the presentation. Hopefully other colleagues are gonna attend and be with us, and you are more than free also during the presentation, but mostly at the end as well. I will look on the chat area to see your questions, and if you have something that you don't understand, of course I will answer. I will look from time to time. I will look also to our chat, like now, to see colleagues like Bogdana, Flore, I think, and Franz as well. Darius, I have to tell to my host, Darius, to close the microphone if it's fine with him. Today is his birthday, so I will apologize him. I can't otherwise. Hopefully you also will. Oh, thank you, Darius. It is done. Perfect. Okay, let's see. So dental adhesion for today. We adhered one to another one with this topic, let's say, in this central and eastern part of Europe, but also till the western part, as we have seen some friends from France as well. I know we are going to have maybe from Switzerland. I have seen to some registered colleagues. And I thought to put a title that would answer also to my question as a dentist, which dental adhesive to choose, when to use it as an education, which one on enamel, which one on dentin on cement, how to use it as correctly as possible as a clinical protocol, and why am I doing all these protocol as these clinical steps to have a kind of a reason why we are using them immediately. And it happened generally. As you can see, as you have seen right now, a little monster, a little person, it was my daughter, Roxandra, that entered abusively in our webinar. But I hope she's going to be a very promising dentist, because she, from her first year, since she was born, she loved to come in my dental office, and as a visitor at least, and now she entered again. I think she's going to be a dentist. I don't know what to say about my son, but at least this was a reason for me to go to have a kind of competency or specialization on pediatric dentistry, since let's say my son was born 9 years ago. But this is the clinical part of you, my kind of focused on pediatric and adult, of course, restorative dentistry, as well as aesthetic and preventive. But also, I'm a lecturer in the University of Medicine and Pharmacy, Carol Davila, Bucharest, in the Department of Prosthetics, Technologies and Dental Materials. So this topic of dental adhesion, it's a topic, a passion of mine during my PhD thesis, but also a kind of field of activity in my academic with students. We are talking about these products, of course, at least in the last few years, because in the last 3 years, I can say we have it in the curricula, because since now we didn't have a very specific course or practical course on this topic. Of course, I'm here with you because I'm a consultant. In the last 15 years, I collaborated with KaVo, starting with SPOFA products and continuing with KER, more specific, but also on KaVo equipment as well. And now, of course, we are gonna focus on this topic of current enamel-dentine adhesives. I will make through my slides a brief review of the literature on the use of these adhesive systems, pointing out the advantages and disadvantages of each generation of adhesive systems, because none of them are perfect. As we know, we're not even as a human being, we are perfect. We will study, I could say, 6 types of dental adhesives coming only from Kerr. That it's a leading manufacturer in adhesive systems and a very reliable, and we will see gold standard manufacturer in dental adhesion. Of course, most of you or all of you maybe are clinicians, are dentists, so we will point out these advantages, disadvantages, but more the clinical protocol of applying dental adhesives in some clinical cases. I will try to have a clinical case for most of the 6 dental adhesives that we will discuss today. Of course, at the end of this webinar, you to have a kind of knowledge or a more bright idea which dental system to choose and to buy for your dental office, or at least to add another one to the one that you have already, maybe from Kerr manufacturer or maybe from another manufacturer as well. As we all know, these dental adhesives have undergone a great progress in the last 30 years since they appeared on the market, and they have revolutionized dentistry. We are calling now adhesive dentistry the days that we are living and practicing, with a great impact on the restorative dentistry and preventive dentistry as well, because we are talking now about minimal invasive and minimal intervention clinical strategies to preserve the natural dental tissues. The first impact we have all seen in replacement of the amalgam as a restorative material with the composites for posterior region, let's say, as alternative to the amalgam. And we have all seen what advantages is to conserve the enamel and the dentine, not to take in excess from the tooth tissues, only the decayed tissues, and to have this opportunity to take advantage of the mechanical properties of the natural teeth that are remained around our materials. Of course, so the direct applications of aesthetic materials are the first field where we feel the advantages of using the adhesive systems in collaboration with the composites for the restoration of posterior teeth, but of course on the anterior teeth, because the first time the dental adhesives have been applied in the anterior frontal region together with the first generations of aesthetic resin-based composites. We are talking about preserving, of course, the dental tissues and the whole tooth. When we are talking about the reconstruction of the core and the post, the aesthetic post in collaboration with this system, when we do the post and cores restoration. So this could be maybe the cavity, the 1 to 5 classes of direct composites, and post and cores, of course, are the first ideas to come for us as indications for adhesives and composites. Of course, these adhesives and composites are our daily practice activity and treatments for our patients. And of course, me as a consultant with Kerr, I focused on using all their adhesives that they have on the market, the 6 generations available or still on the market, in conjunction with all their aesthetic composites, whether we are talking about composites that are placed layered, or the ones that are placed as a bulk filling restoration. This area of composites and adhesives, I have applied also as a topic and as a hands-on topic in collaboration with Kerr. We have seen that adhesion is the fundamental of any direct and indirect adhesive restoration. And we have some conditions in which we have to apply these adhesive materials. First of all, we have to think about isolation of the film, but as well the compatibility with the material that is going above the adhesive system. We have to think the adhesive systems as the base, the fundamental of the whole restoration with the composite, thinking that it's a complex of materials, naturals and artificial ones, that are going as a unit together. And we are talking about three departments of materials, let's say. We are talking about the composite as a restoration. We are talking about the adhesive layer. And we are talking about the let's say the enamel and dentin that it's around our artificial materials. But in all these departments, we have to think about the interfaces that it's going to go between them, and that they are depending one to the other ones. We need strong bond strength, let's say, from the the dental systems we are talking about, in order to maintain the composites in the cavities, of course. But when the composite maybe has a bigger contraction of shrinkage stress, let's say, and the adhesion is quite good enough, also the tooth structure comes in this complex and reacts with a kind of bending, a deflection of the cusps, and in some cases we could have some fissures around the composites, or this deflection of the composites could say something about our composite and our adhesive systems. If in some cases the adhesive system is not strong enough to take together the composites in the cavity and in conjunction with the dental tissues, we will see a breakage of the adhesive layer interface. And of course, in 3-5 years, we are going to see the micro leakage. First of all, difference in the color at the margin of the composite, and with time we will see after 4 or 5 years, statistically speaking, the appearance from spots to general, some caries, marginal caries. These things could happen with the adhesive system. When we are talking about the dental tissue, enamel and dentin. And the research group I have worked since 2004 when I was a student, and I have worked for my PhD, is the one conducted by Professor Gary Fleming. And we have done many studies on cuspal deflection and micro leakage according to the class 2 cavities and class 1 cavities. And we have seen that our kind of protocol of research, it's a very similar one to the clinical application of the adhesion. And our cuspal deflection and micro leakage researches could speak, let's say, for the clinical output of our dental adhesives. I didn't want you to focus on my personal research, my in vitro one. We will see mainly this presentation, the clinical cases. But the dental adhesive has a great importance, not only for the enamel or for the dentin. It has a great importance for the pulp tissue that could come very near in the large cavities, and could give us postoperative sensitivity. I could say when we apply the fourth or fifth generation adhesive system, when we apply a total etch technique with the phosphoric acid, we could have sensitivity from our patient or pain also during the clinical procedure, and especially during our let's say drying procedure of the tooth after we wash the acid gel. So the interaction of the adhesive system with the three types of dental tissues are present and are very important, also for the patient, but also for the technology of the dental adhesives, their formulations and their performance during the time. Their immediate action and their, let's say, aging is as well important for us as dentists and for our patients. And we will see that not only the bonding strength of a dental adhesive, the immediate bond strength of a dental adhesive is important, but also the capacity of not getting aged and degraded during time. It's an important issue for the longevity of our restorations. Of course, when we are talking now about adhesive systems, we are not talking only about direct applications. Adhesive system, I have to tell you that if you, and for sure you know that, are going to go together with comprimers and under amalgam materials as well. So adhesive systems are made both for the dental tissues and for direct restorations that are now available on the market, and we are talking about composites, comprimers, and amalgam materials. But of course, with composites we are using them regularly, let's say, as well as in the prosthetic restorative dentistry. In the last 20 decades, we can say that it's also this restorative part has been revolutionized as well, because we don't have to use now only some conventional cements, but we are using some luting cements that are going together with our adhesive systems. And of course, we can adhere now all kinds of partial crowns. This is the main advantage for the adhesive prosthetics, that we don't have to have retentive preparations for our abutments. And we can use very small restorative parts as veneers, as inlays, onlays, overlays. We are conservative also in the prosthetic part, not only in the odontotherapy treatment. Of course, in conjunction as well, we can use these kinds of adhesives with full crowns, bridges, and not the least with endodontic posts when we do that adhesion part of the posts, zirconia or metallic ones that were once also the metallic ones can be used with these adhesives and the resin cements. Maybe the last I have put from the indications that KaVo have in their instructions for use for the last adhesive system that KaVo is manufacturing, Optibond Xtr6 Universal, to see the whole range of direct applications and indirect application of the current adhesive systems. As I have told you, we could talk about complete coronal restoration, to some repairs of some restoratives, about the sealing of cavities or the cervical hypersensitive regions, as well as the core buildups that could be only the coronal part of restoration. Of course, we will see that with the adhesive technology, all our adhesives are developed more compatibility with all kinds of resin materials regarding their type of curing. So we will see when we will approach the universal adhesive system, they are going to be compatible with not only with the light cured composite, but only with the chemo cured or self-cured composites and dual cured resin cements that we are using during our prosthetic procedures or for the coronal buildups. For the indirect restoration, we will see that to the last generations of adhesives, we are going to have a compatibility with all types of restorative materials. It could be all types of ceramics from aluminium-based, sphatic-based to zirconia-based crowns, that the universal adhesive systems are active and could bond to its chemistry of zirconia. Of course, as a cavity sealing, as a pre-treatment for indirect restoration, this is something also used before provisional restorations. It's an indication as well. I have made some classifications that helped me when I first read the first adhesion articles coming from Professor Van Meerbeek. Professor Van Meerbeek is one of the most respected authorities on the topic of bonding agents, and of course the co-editor-in-chief of Journal of the Dentistry, and he has made a 30 years research on bonding systems and all kinds of classifications while using them in his researches. And this classification, I have it since 2004 when I first started as a student to study the flowable composites then and the dental adhesive, being in to the University of Birmingham to a research project. And from there, I know that we can, and it's still available, we can split, let's say, the adhesives in two types of resin adhesives: etch and rinse and self-etch adhesives. Of course, we are talking about self-adhering materials that are already on the market before the composites, before the adhesive systems, and we are talking about glass ionomers that adhere by themselves to enamel and dentine. And of course, also adhesive systems have been developed, but that are resin modified, of course. And we can say also Kerr is a pioneer. We can already talk in the last 10 years already about self-adhesive composite, flowable composites. Flowable composites, because at the moment we can't talk about self-adhesive viscous or bulk fill or stratified restorative composites as a property. We are talking only about composites, stratified or bulk fill, that need for adhesion to the dental tissue, they need a adhesive system. This draw always helped me to integrate one of the adhesives on the market, or one of the adhesives that a dealer came in my office and gave it to me, to classify it or to understand some things, how to apply it, what are the advantages and disadvantages of that adhesive system. This draw has been made by Professor Van Meerbeek only for 4 generations of adhesive systems. It was about, and all the first that we can see in this draw, the 4th, the 5th, the 6th, and the 7th, were the adhesive system that were between 1990 and 2010, let's say. But after 2010 and this moment, other two generations of adhesive system appeared, and they were named as the 8th and the 9th generation, mainly by the manufacturers. Because the manufacturers are the one indeed that are speeding, let's say, the succession of this kind of new compositions and formulation of adhesives, and with new properties and performances. And at this moment, we can say that on the market, we can buy one of the 6 adhesive generations that are placed in my drawer right now. Of course, there are 2 main adhesive modes or mechanisms, let's say, or they have 2 kinds of clinical protocol in general. There are the dental adhesives that are etching and rinsing the acid edge from the tooth, and we are talking about these etch and rinse adhesives that are we are going to see total etch and rinse adhesives as there are the 4th and 5th generation, or we are going to see that some universal adhesive system as the 8th and 9th adhesives can go back to their ancestor, let's say, and adapt also to the total etch and rinse adhesive, so to etch both the enamel and dentine, or the universal one could go only for a selective mode of selective etching of the enamel only, as the 9th and 8th generation of universal adhesives we will see can do. So the etch and rinse mode or protocol is going to be used by the oldest adhesives, let's say, that are still available on the market, and they are the gold standard, and they go total etch both enamel and the dentine, or we can have an etch and rinse selective etch of the enamel for the newest adhesive systems like the 8th and 9th adhesive ones. Of course, we have the 6th and 7th generation that came around 2000 that are approaching a very conservative, minimally invasive, non-operative sensitive adhesion, and they are named self-etch adhesive systems. The self-etch adhesive systems, we have to imagine them are a kind of etch and dry adhesive systems, because we are not using the water to wash out our acidic principles that are demineralizing the enamel and the dentine. You have heard me all the time talking about adhesive systems. I'm saying a system because in order for a resin solution to adhere to the tooth, enamel or dentine, we need to have 3 components in this system. We need to have an acid to etch, to make the micromechanical adhesion retention of the adhesive layer. And we are talking regarding dental tissues about phosphoric acid. We are not talking about fluorhydric acid on teeth. We are talking about phosphoric acid, as you know, with a concentration in the syringe between 35 and 35.5, as Kerr has it in his syringe with the Kerr etchant. We are talking in the 4th generation, for example, Optibond FL has these 3 principles separately in 3 different devices as a package. So we are talking about gel, phosphoric acid gel in a syringe. In the 4th generation of adhesives, we are talking about a single bottle of primer but it's a primer that has monomers that could react with water and enter in the micro retentions made by the acidic gel. So this primer is made for dentin especially, has been developed, but it's compatible, very compatible also with the enamel. So we are putting all these three principles I'm telling you in the fourth generation totally. We are put them both on enamel and dentin. And the third bottle or package, it's the adhesive resin that it's more hydrophobic, and it's the resin compatible both with the primer that is subsequent, but especially with the composite that comes over the adhesive layer. So the fourth generation of adhesive systems is the gold standard till now on enamel and dentin, but especially on enamel. And we are going to see about Optibond FL as the product still on the market since 1990 to present. And that we are going to see is the standard, the gold standard, with which every manufacturer of adhesives in the world is comparing his own newest adhesive on the market. The first three adhesives are not anymore on the market because they approached only the enamel and they couldn't adhere, and gave also debonding, also pulpal problems because they couldn't interact correctly with the dentin. So they have been taken out from all the manufacturers out, the first three generations. We are talking now starting with the fourth generation of adhesive system. The fifth generation of adhesive system, we are going to see Optibond Solo Plus to occur. It's very common in the dental office. Very for sure you have used it, or you are still using it. It's the adhesive that it's using the syringe of phosphoric acid gel, but has the primer and the adhesive resin combined in the same bottle. This is the fifth generation. It's a one bottle adhesive. And these two are the adhesive systems that are named etch and rinse total etch adhesive systems. They are the total etch adhesive, etch and rinse adhesive system. Total etch and rinse adhesive systems. I just wanted to look in my chat. It will last but it is only 1 hour. We are gonna try to make it more easy. I will make also immediately. It's a 1 hour and a half the presentation. You will have also some questions. The self-etch approach, it's the one characteristic, only the self-etch approach for the sixth and seventh generations are the ones that appear around 2000, the years 2000, that are not using at all the etch, the acidic gel, phosphoric acid in a syringe. But these formulations have the acid part of some methacrylate formulations. We are going to see the GDP glycerol phosphodimethacrylates using their acidic property to enter, to etch, and to penetrate into the enamel and the dentin. So we are going to have in the sixth generation of adhesive system one bottle self-etch primer. So it's going to be a primer that is going to have the etching properties on the dental tissues. And separately, we are going to have, again, as in the fourth generation, a one bottle with adhesive resin. So far, these kind of formulations with the primer separately, or the adhesive resin separately of the primer, are the more successful ones. And Professor Van Meerberg researches, and not only his, are still focusing that these are the best and reliable approaches, let's say, for direct restorations and dark cure modes in indirect applications. So this separation, it's still the most reliable on the clinical protocols when we are dealing about the direct application and the dark cure modes in some clinical cases, because of the PhD, that it's more basic to this kind of adhesive resin after light curing. Of course, all this progress has a base of the dentists that wanted to simplify the clinical protocol and to have all the three steps in the same bottle, let's say, to have in the same bottle the acid, the primer, and the adhesive resin, as are the adhesive all in one that we have seen as the 7th generation. And of course, the 8th generation looks like with only one bottle, but it's a self-etch universal adhesive that has a chemical combination compatible with the clinical protocol, also with total etch and selective etch of the dental tissues. And the 9th generation looks like with two bottles like the 6th generation, but is going to have also universal properties to use all the three types of clinical protocols, let's say self-etch 100%, selective etch of the enamel, and total etch. And the 8th and 9th protocols also include in their formulation the chemical component of the silane, so and some catalysts that could the silane that is gonna put the adhesive in the role of a silane, let's say in some indirect adhesive procedures. So they are extending their indications. And of course, the use in dark mode with any kind of composites that we want for universal adhesives. This is another kind of approach of the 8th generation, the 4th generation Optibond Xtr6 with the in three steps, total etch with 2 steps, self-etch in 2 steps, or self-etch in only 1 step, as the 7th and 9th could go. Of course, this is in 2010, we have to say that appeared the first self-etch adhesives on the market. Also Optibond Xtr, without the E, appeared also for Fokker, that it's still of course on the market, but that can't go with the total etch approach. So this is not 100% universal, let's say, even if it was a very good step towards the universal ones. These are the products. Optibond Xtr6, that I said it's the total etch and rinse in 3 steps, or the 4th generation. Optibond Solo Plus is the 5th generation. It's again the total etch approach, enamel-dentine. Optibond Xtr is the 6th generation with 2 bottles separately, but I have told you it's not gonna go on this etch approach on dentine at all. And Optibond all-in-one, it's also still on the market, is the 7th generation that goes very good on dentine, but it doesn't work on enamel without an etchant, and he was formulated not to go at all on dentine with some etchants. He has to be Optibond Xtr and Optibond all-in-one are formulated to go in a self-etch mode. Of course, if you want to put a selective etch on the enamel, it would be recommended. I would recommend it as well if you have a lot of enamel in the restorations. And after the 4th types, already there's 4, 5, 6, and 7. We are talking about the last two products that are named the 8 because it was the first one formulated, the Optibond Universal. That goes very good also on selective edge of the enamel, but also on total edge. But I would go more only on selective edge with the Optibond Universal because it's more hydrophilic, and in my opinion, this kind of adhesive universal need to be put it maybe in 2 layers to be sure, or to be covered with a flowable composite that is hydrophobic. And otherwise is the perfect solution for denting. So for denting, for the quickest clinical protocol, Optibond Universal goes very well. Or the most reliable one that I would choose maybe instead of the gold standard Optibond FL in my dental office that I would buy at this moment, it would be this Optibond Xtr6 Universal that goes in all the 3 adhesive protocols, totally self-etch, so self-etch protocol without any kind of syringe of gel on the tooth, or selective etch of the enamel, or a total etch approach if we would have a non-vital tooth, or medium or superficial or not prepared enamel, let's say. But it's if it's not prepared enamel, that's let's say a selective etch of the enamel if we are talking. Here we have some ideas. We are going to go much more faster on the clinical cases if I'm presenting this theoretical at the first part of the presentation. It's again summary of the main, let's say, adhesives that KaVo are having on the market. Is the gold standard that any manufacturer is using for comparison for the performance. Any adhesive on the market that is going to go on the market now has to perform at least as well as this Optibond FL on the enamel, and so far no other adhesive has overpassed the adhesion on enamel on this Optibond FL when using in direct application, because we can see that this adhesive FL has a very big consistency of anorganic fillers, 48%. They are the first steps of resins towards flowable composites, and this adhesive is very good in direct restorations because it has a very thick layer of adhesive, around 40 microns, that is going to be like elastic layer underneath the composite that suffers a shrinkage during the composite. And this layer, thick layer of adhesive of Optibond FL, is very good in all the cavities, but especially in the 5th cervical cavities where the tooth is bending, because this adhesive is like an elastic buffer that it's gonna retain the composite on the top. And the best results so far for direct application with the adhesive that is total edge is this product on the market. Has a solvent water ethanol, and has, as you see, a primer and an adhesive that and after we light cure this Optibond FL, he becomes towards the pH of 7, so to be a neutral adhesive. That's why this goes very well with all kinds of composites on top. Also with the core composites, let's say, to build up the core on different types of teeth. This goes very, very good. It's not indicated in indirect luting adhesive protocols because it's too thick, the adhesive layer. Only lately, with the newest resin cement of Kerr, it's gonna go, because Nexus Universal from Kerr now on is the thinnest resin cement, and is the first step for Optibond FL to enter in the world of indirect procedures, let's say, because they are going to compensate the resin cement that is very thin layer with this adhesive that is thicker. Otherwise, the other one adhesives are going to be more recommended in the indirect restorations protocol. Optibond Solo Plus, that has around 15% fill as a consistency, and around 10 microns the layer. Optibond Xtr6, the last adhesive from Kerr, that is similar as a layer to Optibond Solo Plus, but with many more other performances than Optibond Solo Plus. Optibond Xtr6 is going to be more self-etch and very good, because he doesn't produce post-operative sensitivity cases as, let's say, the 5th generation with the acidic on the dentine would be. And because Optibond Xtr6 Universal has 2 bottles, so has the adhesive resin that is light cured and becomes also with a pH of around 7 after light curing, a layer that is going to make the compatibility better with all kinds of resin composites on top. It doesn't matter if they are light cured, self-cured, or dual cured. Especially on the post and course restorations. And Optibond Universal has a little problem only after light curing with the dark cure mode, because he remains not neutral after light curing, but more acidic. And in this case, we have to pay a little attention when we use it, the Optibond Universal, in conjunction with resin cements that are from other brands than Kerr. With all the Kerr resins cements, Optibond Universal is going to work, because the resin cements from Kerr don't have a redox system that is old to the other manufacturers. We have to Kerr a redox system that is compatible with all types of adhesives on the market, and especially with his. Here we have the Optibond FL, the total etch technique. We are going to put 15 seconds the acid on dentine and 30 seconds on the enamel. We are going to wash for 15 seconds the acid, very attention, from enamel and dentine. We are going to dry the dentine and enamel, but not to desiccate the dentine. It's very important when we put the acid on tooth for the 4th and 5th generation of adhesive system to remain a wet dentine. That's very important to have a good adhesion. And on that dentine, a little bit moist, we have to put the primer, that is hydrophil. We have to brush the primer, that's very important, 15 seconds. We have to blow to dry, to evaporate the ethanol from all the adhesive systems. We are going to see the last ones, the self-etch ones, have an extra solvent and acetone that has definitely to be blown out to dry it. But now here to Optibond FL, we have only ethanol. We have to dry it from the prime. We are gonna put then the adhesive resin as a brushing motion, not as a light brush motion, only to make the step of sealing of the hybrid layer with the primer. Then we dry again to get out the solvent that is also a little bit in the adhesive, and then we light cure. So to Kerr, at least, all the adhesive systems contain the second part with the photo initiator to be light cured. So the adhesive is the one that is going to be mainly light cured with a less concentration of photo initiator in the primer. And over the top, any kind of composite we know. The micromechanical adhesion is the one that is making the adhesion of the adhesive to the dental tissues. So we have a micromechanical in this kind of crevices that we have done with the acidic phosphoric acid gel. This black part is primer, and this part with many particles that look like a composite, but it's not the composite, it's the adhesive resin. It's like a sealant on top of the hybrid layer that was the combination. This is the hybrid layer, the combination in then also in enamel. So in enamel, this is the hybrid layer, and in dentine, this is the hybrid layer, the combination in dentine between collagen, the fibers of collagen, and the primer that comes in the tooth for the 4th generation. Of course, for the 5th, for the other types of adhesive system, we are gonna see all the mixture of the solutions with the collagen. This kind of collagen that is naked, depleted of a mineral component, is specific for the total etch technique, because over there we put also on dentine the enamel, and this collagen is the one that is gonna, and this kind of hybrid layer is the one aspect that maintains the composite on the tooth, but also with time, this is the part that is gonna be degraded during the years when the acidic phosphoric acid was on the tooth, because that gel in the syringe is so aggressive as acidity, as it wakens, let's say, some enzymes, metalloprotease we say, that are gonna destroy the collagen over the years. And that's why the self-etch adhesives are gonna, let's say, be more durable in years, not with better bone strength, but more durable in years regarding this degradation. Of course, we have to pay attention to the technique to introduce the primer all over this kind of collagen fibers in order not to have gaps, to enter water, and to accelerate the process of degradation. So this is a drawback of the acid also, because it wakens these enzymes, and we have to pay attention. As a clinical protocol to neutralize these enzymes, we can put after the step of etching and drying, we can put a gel of chlorhexidine. Ultradent, for example, Composites, they have a syringe of very light gel that can be put it on the tooth. It's only dried, and then we come with the primer from Kerr and Adhesive. This is a clinical tip, let's say, to overcome the problem of degradation of the dentin over time in the hybrid layer of the collagen. But if we are gonna put very strictly all these steps of protocol, the results for Optibond FL has made it a gold standard in the adhesive world, because this kind of 5-class composites with Optibond Herculite are these cases of Dr. Bogosian, has made very good results of retention, Optibond FL and microhybrid. And after 5 years, 100% of 5-class of composites with Optibond FL without problems. You see, in 2018, we have again, after so many years, almost 20 years, very good results for this material. It's the first adhesive in the world with fluoride releasing fluoride effect, because it has particles based on fluoride salts. And this kind of buffer layer and this preventive antibacterial effects, it's maintaining these products and its success on the market. That's why the adhesives from Kerr have a very strong background and backbone, of adhesion history and clinical performance. This was the standard that still are available on the market. The Kerr stands as a leader in adhesion and in composites, mainly for posterior regions. So this team of adhesion and composites in the posterior region has no competition, in my opinion. Let's say that has studied a lot. In 2019, in PubMed, we can still see that Optibond FL was used is still in all the studies as a control. Of course, this universal multi-mode adhesive, the 8th and 9th generations, benefit from the phosphoric acid gel as bond strengths are better, of course, especially for the enamel surfaces. The acid gel and enamel are the best friends. It's not good, the acid gel, phosphoric acid gel, on dentine. They are, let's say, the worst enemies in this adhesion background. But for the universal adhesives with good results, also Optibond FL and Optibond Solo Plus have clinical confirmation that if we pay attention to the protocol, we have very good results. Other results in Journal of Adhesive Dentistry: how universal is adhesion, share bond strength for multimode to enamel and dentine. Of course, also in the other in this one, we are interested on internal and marginal adaptation of bulk fill composites that are the most recent one with different adhesive strategies. Of course, Optibond FL was again used together with other adhesives, Universal One and Sonic Fill, for example, bulk fill as a composites. Of course, a superiority of the three-step etch and rinse approach was seen compared to the one-step self-etch adhesive. It doesn't matter if it's a bulk fill on top or not. So the etch and rinse 3 steps remain the gold standard so far, and we have to pay attention till now. That's why Optibond Xtr6 is let's say the best twin of the Optibond FL in the self-etch approach. That it's going very close to Optibond FL. Here I have used the Optibond FL enamel total etch advantage of having, we will see a whole tooth with enamel that I didn't touch, and I used premise on top. It was a student of mine with some nanic lateral incisors. Of course, I only brushed and a little bit with some OptiDisc, a little bit roughened the enamel. Otherwise, the gold tissue in the adhesive dentistry, it is the enamel. We wanted in this case the approach of the wax up made by our colleague dental technician. On the wax up we have made the impression. We used, of course, the matrix to build up in composite the lateral incisor, and I have used the Optibond FL because I wanted to take advantage of the etching of the enamel that I have to the maximum, and to use the mechanical, let's say, buffer elasticity of the adhesive of the Optibond FL as much as I could. Here we see the dehydration during, this is the gel etching from Kerr, it's purple. We see the premise on top here, because even if premise has more viscosity, I have the Composites instrument that is making vibration, and it's making a very smooth consistency of this nano hybrid composite. That, in my opinion, has very good properties of finishing and polishing. These are the conditions that we had in my university with my student to make his filling. In that moment, we didn't have the, that was a drawback, let's say. that we didn't use a rubber dam in this clinical case 6 years ago. And this patient, I have to tell you, my patient is a dentist working now in a very good dental clinic in Bucharest that is 6 years almost the 5 years, let's say, the filling. I don't have now I have to make another picture, but he is an alpinist as well. He's crazy about getting on the highest mountains in Romania and all over the world. And these materials have been, let's say, pushed to freezing, to high altitudes, to all the other types of aging conditions, and this adhesion is strong enough to have the rely that it's the gold standard. Of course, when we do with the fifth generation, we have to pay attention to all the adhesives, to shake the bottle before dispensing, because the fifth generation have in the same bottle a primer and adhesive, so the consistency is higher of the adhesion solution when we put it to enamel and dentine. As to the fourth generation, the primer is very aqueous and very liquid. Here we have a much more viscous consistency, and we have to pay attention with this solution to push in the tooth, in the dentine especially, in order all our let's say dentinal tubules that have been emptied by our acid gels to be again filled with the adhesive resin and primer together. Because if we have some gaps remained in the dentine, these gaps are the origin of the pain of our patient. So we have to brush with a high quantity of adhesion and solution, and with all the surface pay attention to fill with the material. Here I have made with another colleague of mine, we have used two kinds of protocols in this teeth from KaVo. We have filled them with sonic fill, that is bulk fill, some teeth versus some layered composite with Herculat Ultra and Ultra Flow. But now I will show you only how it looks, the adhesive that it's also a total H fifth generation, the gel etch, and that is from KaVo, total etch, 30 seconds on enamel, 15 on dentine, washed away. This is the consistency, very good from KaVo gel phosphoric acid. Washing, very paying attention to wash also around the matrices. These are some Metafix matrices. We dry but not to desiccate, to fourth and fifth generation not to have a dry tooth but a wet one, a moist one, not a wet, a moist one. This is the Optibond Solo Plus on the KaVo applicators that I like, because they get filled with adhesive solution when we put on the tooth, and it's more I recommend to use their applicators for application of teeth. We dry the adhesive, that is one component solution, and we light cure. When we light cure, this is another clinical step we have to pay attention in adhesion. We have maybe to light cure more than 10 seconds, let's say, if we have a deep cavity. This is the step when we light cure an adhesive material on the tooth, the most attentive we can be in the tooth, to remain that hybrid layer to be as much as possible light cured. Otherwise they are very irritative for the pulp and prone to degradation of the hybrid layer. And this is the aspect that is correct for the fifth generation adhesive, or for an adhesive on all the cavity. Of course, now so far we focused on the etch and rinse, the total etch adhesives. Now we are going to go to the self-etch ones immediately. Have you understood so far? Clinical tea with chlorhexidine gel after etching. What is the purpose of it? Is it mandatory? It's not mandatory. I'm not using it I use it when I heard about it. Because you are coming from France, Kanwal, I have to tell you, I have learned when I was a student in 2004, two things that I used immediately in my first 5 years of dental practice. To put chlorhexidine, as I told you, and to put the glycerin on the last top of composite on the layer that is inhibited by the oxygen, to have a more complete light curing. And this chlorhexidine, in most of my 10 years last cases, I didn't put it anymore. Because yes, exactly, because it was indeed demonstrated in vitro that it's good for these enzymes, but as well, Kerr has this lack of fluoride releasing, let's say, antibacterial, and the good capacity of the Optibond FL to primer to integrate very well in the dentinal tubules and around the collagen. So it depends on the type of adhesive, how sensitive is the hybrid layer to this degradation. Optibond FL demonstrated indeed that it's the safest, let's say, fourth adhesion generation and most stable regarding the hydrolytic degradation, but other brands on the market are less effective, and maybe with those products, but because we have the self-etching universal ones, maybe our concerns are lesser now about this. And with Optibond FL, I don't bother so much about this problem. Okay. Can we have a PowerPoint or slide because it's too small? Here we can't see anything. We are not on the correct slide. Let's see. I will see now. Am I on the correct slide right now? If I go back, let me see. Now I'm gonna talk a little bit about the self-etch adhesives that are shallower, entering in deep indenting or enamel, but it's more stable in time. The chemical bonding that it is between the acidic monomer in self-etch adhesives and the hydroxyapatite that is present remained in the tooth. Yes. Let's see right now on the etch and rinse. For the self-etch, the 5th and 6th generation, Kerr had a product that used as a sealant this Optibond Soloplast and used a primer, a product that was very acidic before the Optibond Xtr. It was a product that was a few years on the market and that I used on my PhD. That you will see in some sections, but it was too strong acidic, that product. The other products that are still on the product, Xtr Extra, EXTR, and Optibond all-in-one, Optibond Universal, they are more mild self-etch adhesives. So this kind of present self-etch adhesive from Kerr, present the 4 that are on the market, still they leave the smear layer that let's say smear layer, it's after we prepare the tooth, it's a kind of powder, let's say, remained over there and interact with the smear layer and go very deep towards dentine, not very deep, 100 less than the phosphoric acid gel, that's for sure. And what do they, what's the specific aspect of the self-etch adhesive? Is that they do the chemical adhesion to enamel and tooth, and they make the chemical ionic bonds to calcium in the remaining hydroxyapatite that it's around the collagen in dentin especially, unless in enamel, and they make the chemical bond. The universal self-etch adhesives, Optibond Xtr6, Optibond Universal, they have a more acidity during drying the solution, their first layer of solution, and they get more acidic and have a deep penetration also in the tubules, on the dentinal tubules. Something that the 6th and 7th generation are not so deep going, but the universal one have better micromechanical adhesion in companion to the chemical bonding. To all the self-etch, the chemical adhesion is very important on the first step, and secondly, the micromechanical part. To the universal adhesives, this part of micromechanical part is better compared to the first generations of self-etch. Bond strength is better to the universal adhesives as to the 6th and 7th self-etch ones. GPDM is the monomer specific to Kerr. We know, and what has better compared, let's say, to MDP is that it's bifunctional according to the curing capacity of these monomers, let's say. And they are organic phosphoric monomers that adhere chemically to the calcium in teeth, and these phosphoric organic heads adhere chemically also to the positive metallic oxides that we can find in the restorative materials as well. So this part, these monomers make the chemical binding to teeth structures and restorative ones. On the markets, depending on the manufacturer, we encounter these acidic monomers that make the adhesion, the chemical adhesion to teeth. To Kerr, they are the GPDM. Also, Optibond FL contains GPDM technology. So Kerr has gone from 1990 till now in all their progress in all the generation of adhesive on this monomer, and they rely on the chemical as well as micromechanical aspects of this kind of a monomer. And it's a kind of competition between manufacturers regarding the type of monomer. Each one with the advantages and disadvantages, let's say. The chemical bond maybe so far, because it was a little bit more studied, the MDP, on the kind, not it's not better on the bond strength, but it's with very good results on the durability of or resistance to aging of this MDP more than GPDM. That GPDM results are linked to this gold standard adhesive, so the clinical background is more powerful, GPDM. This is a personal study that I have made 10 years ago on some molars with class 2 cavities. With in each molar, half of the tooth was with the class 2 in enamel cervical part, and on the other half of the tooth in let's say cementum or radicular part below enamel cemental junction. Optibond FL had impeccable results on enamel 100%, with some drawbacks related also, but to very few number of let's say teeth on dentine, let's say, better than, it's easier for me to say dentine. Optibond Solo Plus, very good results on enamel. with a few drawbacks on dentin. So in very deep cavities, the 5th generation could have not to be very predictable, let's say, regarding the micro leakage of the adhesive. This was an attempt with an adhesive that it's no longer on the market, that had the primer very acidic. It was so acidic that has washed all the calcium hydroxyapatite and was not good in penetration and sealing around that tissue, and the results were not good. But Optibond all-in-one, the 7th generation that those years has appeared in 2009 around, had very good results on dentin, on very deep cavities. I am open-hearted recommending you to use these all-in-one products, as Optibond all-in-one, as Optibond Universal as the 9th generation, as they are very good chemically to the calcium in this area. When regarding to enamel margin, this 7th generation was not good, didn't have so good results, because was not so acidic as a self-fetch property to demineralize the enamel that is more mineralized. So from this, my research in 2010, I realized that a self-fetch adhesive when using in a cavity with enamel margin, we should recommend the selective etch of the enamel. In 2010, in the literature, in the product instructions for use, they didn't mention about selective etch enamel. But with time, as you can see, with the next generation of adhesives, this came as a reality and recommendation also in the literature, as in the prospects of the products of the universal one, to add, if you have enamel, to be more reliable and sure, to put the selective etch of the enamel. And I had the same ideas for my these ones. Optibond Xtr, after in 2010, Optibond Xtr came as a replacement of that adhesive that you have seen that had very bad results on enamel and dentin. So Optibond Xtr, the simple one, came after seeing the bad things from the first attempts of self-etch and taking the advantages of Optibond all-in-one on dentin. And to Optibond Xtr IFU, instructions for use, we are gonna see in 2010 that also car manufacturers recommends, if we want to put on enamel selective edge, we can do. But this Optibond Xtr6 generation, it's not recommended with a total etch technique. Can't go, it's not recommended on dentin. It's better to work on dentin on the chemical mechanism of this adhesive system. So we can see we have to brush very good the primer to let the acidity, to let the penetration. We blow up the acetone and ethanol, and then we make a sealant as a cover with the adhesive resin. We dry it and we light cure it, and then we come with what kind of composite we want to put on the top. In 2010 appeared this Optibond Xtr6 generation, and in that time appeared the first bulk fill sonic activated composite, and I had the luck with the help of Kurt to use them both in my university. And those immediately when my patient came, I said to make some photos also for one tooth. I didn't want it to replace the other two, because also she didn't want, but I wanted to put the rubber dam in the next pictures session. Here I had a deep cavity, but not symptomatic. I put a base with Caviton resin modifying glass ionomer. That was polyacrylic conditioner, that it's blue. And then I have taken the snare layer, and afterwards I have put it, I filled as much as I could with that base, and then I put it the recently achieved 6th generation self-etch adhesive Optibond Xtr primer adhesive. As you see, Kerr has for all their adhesives the unidose. This is in these times of coronavirus and more protection for us and especially for our patients, we should go with this approach. I think now it's a must to buy. I would recommend, or for me, this is what I am going to do, to use the unidose adhesives from now on. One, to avoid the cross-contamination with all kinds of viruses, from coronavirus to hepatitis B, C, HIV, and to have the best chemical formula of the adhesive, the one that the manufacturer is giving us, to have that chemical adhesion and consistency and combination with the solvents, and as the Kerr manufacturer is giving me, to have also the properties. Of course, we have a maximum 5 millimeters deep possibility to put this composite as a bulk fill. And here is the bulk fill together with the Optibond Xtr. This is the second session. As you say, I put it a rubber dam. This is now in the coronavirus time. This is definitely a mandatory one rubber dam for the avoid cross contamination, especially from the patient to us as dentists, and secondly, because indeed all these adhesives and composites work perfectly or better in isolation with the rubber dam indeed. And of course, we put it the Optibond Xtr with the sonic fill. And we had some after 1 year, this image is Optibond Xtr, so the 6th generation self-etch with sonic fill bulk fill, 1 year and 3 months. And this is after the prophylaxis, let's say, image of this with, of course, no post-operative sensitivity, even if he was a parodontopath patient, and without chromatic changes at the interface so far. Here it's another clinical case with this Optibond Xtr self-etch 5th generation 2-bottle adhesive on a patient around 25 years with endodontic problems. We wanted to make some post and cores. At that moment, we had 2016 this system from Spofa that is part of Pentron right now, and the name of these products is different at the moment, as Breeze and Build It. Breeze instead of EasyChem, and EasyCore is the Build It that they already have. This is what I know, but I'm not quite 100% about the correspondence of names, but that this is what I guess it is now. Of course, there are 2 protocols for post and cores. We can have a protocol to use a self-adhering resin cement on the radicular part, and to use on the coronal part adhesive system and core resin cement. Or we have the second type of protocol. We can use the adhesive system from up to the bottom. We can use the adhesive system whatever we want from all those 6th generation I presented to you, in accordance with the resin cement that it is dual cured, easy core. But as I mentioned in my presentation classification, I would recommend, I would not recommend the adhesive systems that after light curing they are acidic, because they are not letting the dual cure resin cement to cure in the radicular dark cure part. So Optibond Xtr or the two bottle components system adhesion would be very, very good. Optibond FL I would not recommend because it has a layer that is too thick, unfortunately, for this radicular part. But I would go for the 6th generation of adhesive systems that after like curing they become pH neutral around 7, as is Optibond Xtr. So, or Optibond Xtr as well has this idea. The lateral incisor is going to be with a self-etch, self-adhesive luting on the radicular part, and the central incisor is going to be with the adhesive system used from up to down. The lateral the lateral is going to be with EasyChem. It's a self-adhesive resin cement that goes well on the dentinal radicular part. And we don't have sensitive procedures as when using a system adhesive on the radicular part. It's a kind of MaxChem Elite, let's say, on the radicular part. And then the central, when we come on the coronal part of the lateral incisor, we are making a selective etch technique in conjunction with that Optibond Xtr6 6th generation, as we say, after washing and drying. Also, the dentinal was not covered. The enamel can be dried very well, not the dentin if we put a total edge, but here it was a selective edge only on the enamel. And then we came with the easy core on the coronal part after we have put the primer, self-etch primer for Optibond Xtr and self-etch adhesive, dried each of them and light cured, and afterwards put the easy core on top. And on the central incisor we have put the adhesive system. We have put it here, the self-etch, the etch, total etch approach on the coronal part, and on the radicular part we have let only the self-etch approach, and we washed. The universal adhesives were needed after that Optibond Xtr generation 6 or 7 generation, because the universal adhesives are the one solution that could go in 3 modes of clinical protocol. We can use the same adhesive material in total etch technique, selective etch technique on enamel, and self-etch technique. We want a layer that after light curing is more hydrophobe and towards neutral, not acidic. We want adhesives universal to be compatible with light cured, self-cured, and dual cured materials. As I said, we want the pH not to be acidic after light cure, to be as thin as possible, the adhesive layer, but it depends on the products, because to be thin, and if it's not hydrophobic but it's hydrophile, it's going to be permeable for water, and we have to put a sealant on top, second layer or of adhesive, or maybe a flowable composite on top. And ideally for universal adhesive to be in 1 bottle, but for the moment it seems the 2-bottle universal adhesives are more reliable and predictable regarding their sealant capacities and compatibility with the composites on top. The 2 types of Optibond Universal. Let me see what's our time. We should be as quick as possible to try to end. Okay. I have talked so far. So this Optibond Universal, I talked, it's the 18th generation. It's an all-in-one but universal adhesive. as a big background. For me, it was a very good acquisition for the young permanent teeth, let's say, to have very quick application for young patients on permanent teeth of restorations on young teeth with big pulp and very good superficial adhesive chemical adhesion to dentin and enamel with no postoperative sensitivity. It is the most compatible to the pulp possible, these self-etch adhesives, the universal one, all in one bottle or in 2 steps. It's very good if you don't want to have white lines when you make front teeth restoration, as Optibond FL maybe has an advantage for a class 4 white line aesthetic point of view. This is the thinnest layer in Adhesion as a generation, this universal one. I would recommend it. Also gets very well with the latest resin cement from KaVo. Optibond Universal, if you want. Then the compatibility with resin cements, this is a fact that all the system adhesive and resin cements are getting very serious. And Nexus Universal is the last resin cement, Lutic resin cement, that goes with any kind of adhesive from the market, and especially from KaVo, for example, with the lowest resin cement thickness that goes in any kind of light cure, dual cure, self cure mode, in conjunction with all kinds of adhesives, including Optibond Universal. So here it doesn't matter Optibond Universal pH in conjunction, because the chemistry of the resin cement doesn't matter about the acidity of the adhesive. And Optibond Xtr6, as I said, is the 9th generation that has gained all the knowledge, the success that has seen all the disadvantages of all the others adhesives. And is a 2-bottle with a primer that it's very acidic when you applied it and you brush it. It gets more acidic when you dry it. Then you put on top the adhesive as a sealant from the second bottle. You dry also the adhesive and you light cure all this complex. So all the indications that you want for the moment in adhesive dentistry, direct restorative and indirect restorations, are in this Optibond Xtr6 from KaVo, with very good ratings on the market. Optibond Xtr6, I use it with Harmonized, the last nano composite, very aesthetic from KaVo. That we use it also in different last year in these times of spring. Of course, I already have it in my office. The last year I didn't have so much time to make pictures and clinical cases for KaVo, but I know I tried it to a traumatic Sunday patient on some front teeth with the self-etch approach of this Optibond Xtr6 that gets very good self-etch approach also on unprepared enamel. And here in traumatic teeth, I don't want to put acid gel etch on teeth. And also I have 1 year very good results with maintenance of these, I said, provisional fillings that are still for 1 year without any problem in the self-etch mode. Of course, we can use the etch and total etch mode with this adhesive, or the selective etch. Depends on you, on how much enamel you have. If you have a lot of enamel for a direct let's say direct restoration on a lot of enamel, I recommend you, of course, to put acid, because it's no dentin to take care about the dentin problem. Of course, if you have abutments that are not from dentin, you can put again to have more decontamination, a little bit of more retention, you can put the acid on the tooth. It's universal. You don't want a silent, you don't want a dual cure activator, because when you light cure the adhesive part, it's neutral, it's not acidic. It depends on the sandblast, on the type of ceramics, if it's glass, lithium disilicato, or if it's oxide ceramics. You can put the adhesive part that contains the silent principles of this adhesion. And if you use Optibond Universal, you need to use it in conjunction in dark cure with Kerr resin cements. And if you use Optibond Xtr6, you can use it with any kind of resin cement on the market you want. Of course, also with the Kerr ones. So Optibond FL, Optibond Xtr6 Universal at this moment are the system adhesives that cover most of the indications in direct restorations, but Optibond Xtr6 is the one that gives you good results both in direct and indirect restorations. Vertice Flow is the first appear in 2010 for self-adhering composite material, but it's flowable. You need to brush it, but you need, if you have only enamel, it's not really self-adhering, so it has some drawbacks on the enamel, not prepared enamel. So we have to put acid on the enamel if we put this self-adhering. It's not quite self-adhering on enamel, only self-adhering on dentine, we can say. And I have very good results from this Vertice Flow for very small cavities and for sealing, Pitt and Fisher sealings, but in conjunction with acid, phosphoric acid, and with the 10 years already very good feedback, let's say, from this self-adhering. Self-adhering very good here. I use it as a liner, a total liner, without putting the enamel, the acid at all here on these cavities, and again a 10 years feedback. Okay, I thank you very, very much for all your attention. If you are still with me, and if you have some questions, I will be also my friend Roxandra, I think, send me some greetings. I say you hello, Roxandra. Hopefully I was on your, I explained as good as I can. And I would like to thank you to be with me. And I wish you good luck and success in your new time of after pandemia, and to take care of you and your patients, and to keep safe and healthy. Thank you. Radosveta, you was the one with me till the end. Thank you. Saying greetings and hello. Hopefully I was as I could to be good understood. Okay, see you, bye. Take care of you, all of you. Darius, bye-bye. Anton.
Thanks a lot.
Thank you, bye. Have a great day, Darius.
Thanks a lot. Have a nice day. Bye.
Bye.